Good afternoon. Thank you very much, Dr. Tejas Bhai, and once congratulations for this conference. So, two more molecules. One is the lipids, which Dr. Kamal Sharma said. Another one is the breaking boundaries with the Ticagrelor monotherapy in the high-risk patient. So we know balancing that is the ischemic and the bleeding risk. There is a sweet spot because we know majority of the risk factors which are likely to cause more ischemia, but same factors are more likely to cause more bleeding also, just like the CKD, diabetes, and so on. So we need to balance them, and we know that as the time passes, after the 30 days, the ischemic risk which goes down and the bleeding risk which persists. So let's first understand indication of the Ticagrelor monotherapy, not indicated in the CCS patient without PCA, but high bleeding risk patient. What is the default strategy? That is the aspirin and the clopidogrel we give for 1 to 3 months, and then we continue either aspirin or the clopidogrel. Default strategy would be that when the patient is having and has undergone the angioplasty, 6 months we give the DAPT and then either aspirin and the clopidogrel, or else how can we shorten the two important thing, whether we can shorten the DAPT or switch to monotherapy. This is the concept progression of the ischemia and the bleeding risk in the ACS patient as the time passes. After the 30 days, ischemia risk which goes down, bleeding risk which remains persistent, and possible DAPT de-escalation strategies that is in the ACS patient. So what is that? Either we can switch to from the stronger P2Y12 inhibition to the aspirin to clopidogrel, or clopidogrel monotherapy, aspirin monotherapy, or ticagrelor monotherapy. So this is about the de-escalation in the patient. This is important study that if the patient is having the higher ischemic risk, then the shortened DAPT will be there. And if you think bleeding risk is very high, then we can shorten the DAPT, and the ischemic risk very high, where we de-escalate from the stronger P2Y12 to the clopidogrel. So let's come to this slide later on. So various trials that we need to rationalize for the aspirin-free strategies in the ACS patient. We know that aspirin-free strategies in the cardiovascular disease and the cardiovascular stroke prevention, because the presence of the strong P2Y12 receptor blockade, the aspirin provides the little additional inhibition of the platelet aggregation. So there is little to no additional platelet inhibition with aspirin in the presence of the potent P2Y12 inhibition, that is the ticagrelor and the prasugrel. So looking back at the Plato trial, low dose aspirin, high dose aspirin which impedes the ischemic protection of the ticagrelor. So if less is more, could none be even better? Means whether we can remove the aspirin and without paying any ischemic penalty, that is more important. So let's go for evidences what we have. The first, that was the TPASS study. There was a discontinuation of the aspirin, continuation of monotherapy in the form of ticagrelor as early as the 16 days, but we have to understand this was the biodegradable polymers in this study. And what was the result? The 46% relative risk reduction in the net adverse clinical events with the ticagrelor monotherapy, and majority it was in the form of the reduction in the bleeding without paying any ischemic penalty. So death, MI stent, thrombosis, and the stroke, there was no much difference. But important, we can see that major bleeding, it was reduced when it was monotherapy after the 16 days. Another important study, that was a Twilight study, ticagrelor monotherapy at the 3 months of the PCA. And here, the acute MI, they were not included in this study, and the high-risk patients, they were included in the form of left main and the bifurcation, multiple stents. So ticagrelor and aspirin, they were continued for the 3 months. At the end of 3 months, the ticagrelor and aspirin were continued in the one group, and another group, ticagrelor monotherapy, was continued. And this was the result of the Twilight. Ticagrelor monotherapy after 3 months of DAPT versus ticagrelor DAPT significantly reduced the bleeding. This is very important because the ischemic penalty was not paid in this discontinuation of ticagrelor. And by type there is 2, 3 or 5 bleeding, it was significantly reduced. Another, that was the TICO study, the Ticagrelor Monotherapy at 3 months from the PCIs. This was acute coronary syndrome, and nearly 40% of the patients, they have acute myocardial infarction. The similar strategy that the aspirin 100 milligram and the Ticagrelor 90 milligram twice daily continued for 3 months, and then Ticagrelor monotherapy was continued in ACS patient. And we can see that bleeding risk, it was reduced. So when the patients were having the high bleeding risk, without paying any ischemic penalty, we can switch to single antiplatelet agent, that is in the form of the Ticagrelor. This is the Panther trial, then 11% relative risk reduction in the MACE with the P2Y12 monotherapy versus aspirin over 24 hours of the treatment. So coming back to this slide, when the short-term DAPT with the potent P2Y12 inhibitors, it was switched to aspirin, and the decreased P2Y12 inhibition, we can see that bleeding events, they were reduced, and the ischemic penalty may be increased if it is aspirin monotherapy. Ischemic events may be increased in this case, but in case of Ticagrelor monotherapy, we can see the bleeding events, they were reduced without paying any ischemic penalty to the patient. So personalizing the Ticagrelor strategy per patient ischemic and the bleeding risk in the ACS PCI patient, we can see that then high ischemic risk and the low bleeding risk, 4 years Ticagrelor DAPT is required. High ischemic risk and high bleeding risk where the single antiplatelet, we are planning to give the Ticagrelor single antiplatelet for 2 years. Low ischemic risk and the high bleeding risk where Ticagrelor single antiplatelet continued for the 12 months, and the low ischemic and the low bleeding risk where we can continue DAPT for the 12 months. So mapping the evidence to target the ACS patient profile, like we have if elderly frail patient, 50 kg, and the strategy in this patient when there is high bleeding risk, Ticagrelor DAPT will last there 1 month, and then it is Ticagrelor monotherapy, that is the TIPAS trial. Another patient when there is the high bleeding risk with multiple stents, that is the Twilight study. Like a patient is having the male patient 65, where this Ticagrelor DAPT followed by the after 3 months single antiplatelet in the form of Ticagrelor continued. And the high ischemic risk, there is the Pegasus trial where the Ticagrelor DAPT for the 1 year, and then de-escalated Ticagrelor therapy to 60 milligram for another 2 to 3 years. So are these guidelines warming up to single antiplatelet strategy? Yes, ESC 2023 ACS management guideline saying that de-escalation therapy of the P2Y12 receptor inhibitors, that is switching from the Prasugrel or Ticagrelor to the clopidogrel therapy, it's to be, but we should not do this in less than 1 month because it is the class 3 indication. So this is from my side. I would say, what is the de-escalation, re-escalation? Either you have the strong antiplatelet and you have the aspirin, either you can switch to Ticagrelor or the Prasugrel, that is after the 3 months, or you can decrease the dose of Prasugrel, that is from the 10 milligram to 5 milligram, or Ticagrelor 90 milligram to 60 milligram, or you can switch to clopidogrel therapy plus aspirin, that is the P2Y12. When there is strong P2Y12, you can go to the clopidogrel, and you can continue only aspirin. So these are the various choices we have according to the ischemic risk and according to the bleeding risk. To summarize, choice of appropriate antiplatelet strategy personalized to the patient needs to crucial to achieve the sweet spot of platelet inhibition and balance the ischemic and the bleeding risk. Short-term Ticagrelor DAPT with de-escalation to Ticagrelor monotherapy, as I've shown that in the various high-risk patients and in acute myocardial infarction. I think Neo Mindset trial, which is from Brazil, probably going on, which may be in the ESC, where the right from the first day only Ticagrelor, they are doing their study. So this is all about the de-escalation, and these are the various antiplatelet monotherapy trials, and I think 100% ACS, 158% ACS. So various kind of the patients in this study were found in new mind study. I think in the coming ESC we may get. Thank you very much for kind attention.
I hope all of you are completely tired, exhausted, and drained out after these 2 days heavy, exhaustive session. And I believe everybody has learned something. As a course director, I also came to learn a lot of things, and I am again extremely indebted to all my international guest faculty friends who have come all the way and participated wholeheartedly like every year. In TRICO, we are hardly changing any international guest. It is almost the same format, same situation, only very little difference, and we try to accommodate all new things. All my national guest faculty friends, I am thankful, and of course the participants. And next year, we will be meeting in month of February. I will be finalizing the date and we will announce. Look forward. Thank you very much.